Why don't you take a seat? So we're going to be introducing Emily Hattwick. She's going to be talking about fetal upper limb anomalies, impact of counseling and postnatal management. And we've just heard her, I don't want to say sordid past, but amazing number of years to get to where you are.
Could be sorted.
We're so lucky to have you with us, and really thank you so much for coming early this morning to talk.
Absolutely. So the appearance of this slide looks a little different, which means that the somebody tinkered with it. So I hope that the sequences come out okay. So, anyway, initially I had thought I would talk about upper and lower limb anomalies, but as I started looking into the lower limb anomalies, there's a lot that would need to be shared that's really not my area of expertise, and I didn't feel comfortable telling you a lot about that without it being. So I'm just going to talk about what I know, which is usually the right thing to do. Oh, all right, that looks right, yeah. So this is just sort of what we're going to do today. We'll go through normal fetal limb development. I suspect you all know that even better than I do. Also briefly go through ultrasound findings. Again, you know that probably better than I do. But what I know and that I'm excited to share with you is what are the common things that I see that we can talk about in a counseling scenario with the perinatal visit, and then briefly review what we do for them, because I think that's the thing that everybody wonders, and it would be nice for you to see some of the outcomes of what we do. So congenital upper extremity differences, there was a study, a Euroscan sort of survey of 700,000 births in 2004, that found 1 in 91 births had a congenital anomaly, looking at all anomalies. In the upper extremity literature, the numbers are somewhere between 1 in 500 to 1 in 600-ish deliveries have an upper extremity anomaly. And the diagnosis obviously is increasing. Interestingly, there was a study that came out this year, a survey of fetal medicine centers, and there are 59 in the country, at least in that article. Maybe you guys know if there's more now, but majority of them are associated with children's hospitals. I know several of my colleagues who do what I do are affiliated with fetal medicine centers doing the prenatal counseling similar to what I do. So increasingly, it's something that we need to make sure we address. This obviously is not the standard imaging that we're getting in our fetal medicine conferences. I don't know how much do you guys even use 4D ultrasound? Is that fairly common?
Yes.
Okay. I haven't actually seen a lot of it here, but in our meetings, it does come up, and we do talk through the info.
If there's an anomaly, I use the 4D all the time to try and show the family, because I think that it really shows it in a much clearer way.
Yeah. Well, of interest to me is that a lot of times, you know, I speak very generally, and we'll go through that in a little bit, but these images actually let you get quite specific,
yes.
Which is nice. And so what I don't know, because I haven't had enough experience with these, is how much the specific image here is not quite what you see when they're born. So I can't comment on that.
I have to say that image is the penultimate of the, you never get something that looks that good.
You know, I think
the placenta is always in the way, the fetus is looking away.
There's not enough fluid around the
baby.
baby. Some people show their very best, but in day-to-day practice, it's very hard
not
to get an image that looks like that. That's amazing.
Well, that's good, because I feel like I always, in a sense, am hedging my bets when I discuss, you know, outcomes, because the images are what they are, and you can only make so much specific decisions about what you see. Obviously, your decisions are better than mine. But the prenatal identification of limb deficiencies, at least in a few studies that I looked at, is good, but there are also, because of what you're saying, there are limitations to what you can see and limitations to how well they can be specifically identified. One study reported 23 to 46% appropriate identification when paired with the postnatal examination. These images are just from an MRI of a patient who I was asked to consult on. And what I thought was interesting is the MRI images are beautiful and clear, and for me show the best absence of hand on the right, absence of fingers on the right, and presence of fingers on the left, but you just really have a hard time identifying how many and what the differences are. Here is the MRI. This is the same patient on the top and the bottom. MRI on the top, ultrasound on the bottom. Again, I'm not an expert in these images, but I certainly am able to take what is seen on the image and pair that with what I know I see in children who are born with deficiencies and talk about things like brachydactyly, syndactyly, radial deficiency syndromes and things. So on the bottom, the radius is short for gestational age on the right image compared with the left image. So briefly going through prenatal development, after fertilization, at 26 to 28 days, the limb bud appears, and by about 52 days, the hand is completely differentiated into fingers and thumb. So most genetic-based congenital hand anomalies arise during that first 4 to 8 weeks of gestation. The development of the limb has been described in 3 different directions, and the genetics associated with differences also are applied to these 3 different directions of development. So the proximal distal elongation of the limb is basically the length of the arm. The antero-posterior differentiation of the limb would be the radio-ulnar differentiation, or preaxial and postaxial differentiation. And then the dorsal-ventral differentiation is palmar to dorsal differentiation in the palm and the forearm. So this is paired with sections of the limb bud that are each responsible for each of the different areas of differentiation, that is elongation of the arm, radial to ulnar differentiation, and dorsal to palmar differentiation. So the apical ectodermal ridge is responsible for elongation of the arm and hand. The zone of polarizing activity is responsible for radio-ulnar differentiation in the fetus. We have found in studies in mice that if you move the apical ectodermal ridge, you can produce an ectopic limb. So if you shift it and put it somewhere else on the body, you can produce a limb coming off of the abdomen or coming off of the back or whatever. Again, some of you may really be very aware of this. And then if you just remove the apical ectodermal ridge, you don't get a limb. There have been lots of associated factors that influence how well these regions work. Fibroblast growth factors 2, 4, and 8 have a significant impact in the apical ectodermal ridge, which is, again, longitudinal development of the arm. The zone of polarizing activity is on the posterior aspect of the apical ectodermal ridge. Again, that is responsible for radio-ulnar differentiation. That is influenced by sonic hedgehog protein as well as retinoic acid. But as they've gone on to better delineate how these hormones and factors influence development, they're not unidirectional in their influence. Sonic hedgehog protein has been shown to have an influence as well in apical ectodermal ridge. So we're still trying to understand the multiple ways of identifying factors responsible for differentiation, and then understanding how those factors either positively or negatively modulate the other areas of arm differentiation. That will come into play when we talk about the classification system. Homeobox genes are well known and understood to be involved in bodily segmentation during embryonal development. There are more than 40 homeobox genes that have been identified. They are grouped and they go past D at this point. They are each on a different chromosome, and again, their role and modulation by other factors continues to be evolving. I won't go into a lot of detail for that. The etiology of upper extremity anomalies generally is thought about as either a genetic underlying mechanism, an environmental mechanism, and sometimes it can't be elucidated and may thought to be a combination. The one thing that we frequently run into is that almost every mother at some point during counseling says, what did I do? I did something and that's what caused this. And so I, again, feel as part of the counseling for me is to reassure them that frequently it's not something that they did. It's just an event that happened out of their control. Genetic malformations can be described as chromosomal, polygenic, or Mendelian. Some examples of chromosomal malformations would be trisomy 21, in which you get a Simeon-Palmer crease, short middle phalanges and syndactyly. Turner's and Klinefelter's or some other chromosomal anomalies that produce hand changes.
Klinefelter.
Mm-hmm. Yeah, I see brachydactyly commonly in the hand. Mm-hmm. Yeah, and sometimes you'll have sort of a partial syndactyly that will be sort of short fingers with a little bit of webbing. Mm-hmm. Not a true syndactyly like we see in Down syndrome where you get a complete syndactyly, but they'll frequently have a little bit of distal webbing.
Down syndrome and syndactyly?
Commonly, yes. Yeah, actually very common between the third and fourth fingers is a complete syndactyly. One of the pictures I'll show you will be from a Down syndrome.
Yeah, my goodness. Did not look carefully.
Polygenic examples would be macrodactyly, and spina bifida has been shown to be related to multiple changes at multiple gene loci. Finally, examples of Mendelian or single gene anomalies would be cleft hand. There is a subset of cleft hand deformities that are autosomal dominant and have been clearly followed through families associated with chromosome 10. Also associated with FGF8 production. Other single gene Mendelian type anomalies are associated such as sickle cell, hemophilia, and Marfan. And the things that I tend to see in those scenarios are not genetic differences in the hand, but rather subsequent results of ischemic vascular disruption. Environmental exposure, briefly, there's a long list of things that are associated with changes. Specific to the upper extremity, thalidomide is associated with phocomelia, where the intercalary segment of the arm or the leg is missing. So, for example, the hand would be coming directly off the shoulder. Cocaine is associated with amniotic band syndrome. Alcohol is associated with proximal radial ulnar synostosis. Smoking has been associated with amniotic band, syndactyly, polydactyly. Those articles are typically not prospective and not as reliable, but there are multiple articles suggesting that association, so it's worth noting. Misoprostol has been associated with transverse deficiency, amniotic band syndrome, and arthrogryposis. Anti-seizure drugs are associated with digit anomalies and chorionophili sampling, which I'm sure is a topic of conversation about whether that causes anomalies in this group, has been associated with transverse limb deficiencies. One of the common underlying pathways seems to be some kind of vascular disruption. There is an increased incidence of digit anomalies in mice with maternal hypovolemia. A lot of the environmental exposures that we just reviewed, the final common pathway seems to be some form of vascular disruption. And even amniotic band syndrome, which Dr. Bulis and I have talked about a little bit, in the literature there seems to be arguments about what is true amniotic banding, what is banding from a physical impact of a band, and what is looking like banding that may be more likely a result of a vascular disruption. So I think there's still some understanding of that. And again, I have some pictures of that coming up. Again, the incidence of upper extremity differences varies. In Australia, 1 in 500, 3 per 10,000. Slightly more common in boys versus girls. About 50% of them present as bilateral anomalies, and 17% of patients with upper extremity anomalies have multiple other areas involved as well, other organ systems. Our classification for upper extremity anomalies is not as useful as we wish it would be. The initial classification system was introduced by Swanson in 1964 and has been modified many times. It seems like every 5 years we come up with a new modification of the classification scheme. And the reason behind that is it's an inadequate system. There are anomalies that cross the multiple categories. So this is an example of a patient who has failure of formation of the central digits, or a cleft hand, and has failure of separation or syndactyly of some digits, and has an angular development or clinodactyly of a digit. So this doesn't fall cleanly into the classification system. So I think there are some specific anomalies that the classification system is helpful for, and I'll be showing you those. But in general, we use the classification system as a help to discuss things in the literature, but ultimately I think we're going to come up with a genetically based system that will be most helpful to us. One of the key elements that I stress with families that I treat is that treating these anomalies is important to include multiple members of a team to help the family. The child and the family, of course, are integral, as is the pediatrician. I have a role frequently for surgery. The social worker can be very helpful. I rely heavily on occupational therapists to help me with both the children's development and the family's adaptation and modifications for activities. The geneticist and the counselor, the orthotist, the prosthetist, and then for me, when we have surgery, I rely on pediatric anesthesiologists. Again, I mentioned earlier that parental anxiety is a common thread in treating these families, and so we always spend a few minutes talking about parents' expectations for their children, the loss of those expectations, modification of those expectations, and I spend a lot of time talking about the child's potential and asking the family not to underestimate that and to realize that the hand anomaly does not spell the end of the world for their child. Why the hand is important? Obviously, the hand is critical to how we function. We interact with our world using our hands, dressing, eating, playing, working, and all of the treatment and all of our goals with respect to the hand and upper extremity are guided by these functions, by the ability to use your hands to do what you need to do. That doesn't mean you need a five-fingered hand on both sides to get those functions done, and so I stress that a lot to families as we go through. Again, occupational therapy has a critical role for me in working with my patients. This child, as you can see, has a three-fingered hand with a polycystic thumb and is learning to do fine motor activities there. Many families will watch their child do things that they thought they never would do and will be completely surprised at the success that their children have. And so the newborn parent doesn't understand that. The parent of a 2-3-year-old says, of course, they do everything. They hold their bottle. They pull on the Legos. But so the newborn parent needs to be reassured that things will be okay. The other thing that I think is very important in longitudinal understanding of how to treat these patients is looking at our outcomes. So I work with my therapists on measuring pre-op and post-op outcomes, trying to make sure that what we are doing, our interventions with things like bracing and stretching and surgeries, do produce improved functional use. So we do measure our outcomes as often as we can. The need for surgery, this is a question that I get from every family that I have come up to counsel, is are we going to need surgery? And so the need is dependent on the diagnosis. And the diagnosis, in my mind, can't be made until the baby is born. But the information that we gather from the imaging studies is excellent at giving a direction in terms of thinking about potential diagnoses. And then that lets me briefly discuss potential for surgery. Again, function guides all of these decisions. The age of surgery depends on both of those things, function and diagnosis. The majority of surgery that I perform is after age 1. The risk of anesthetic complication goes down after about age 1. And the most of the upper extremity anomalies that, well, I can't think of a single one that is life-threatening. So I would prefer not to threaten the child's life from anesthesia or for a non-life-threatening upper limb.
But it is primarily an anesthetic reason?
Right. So for me, it's primarily, no, there are certain things that are easier, but they're also small that the difference between 6 months and 1 year is not enough that the size of the item is going to be functionally, is going to be surgically limiting. Right. So for me, it's all about anesthesia. Occasionally, they do need surgery before age 1, and here are some examples. In constriction ring syndrome, so there are some multiple words that are used for this. Constriction ring syndrome is the same as amniotic band syndrome, is the same as Streeter's dysplasia. Those are all words for the same thing. And again, there's some interesting conversations, and because Dr. Bielis and I have talked about it, I've been doing some more reading, trying to see what is the mechanism behind this, and there's a lot of different articles. Some articles really see an actual band that detaches from the uterine wall and wraps around and causes significant damage to the fetus. Other articles suggest that there was maybe a vascular disruption, and this constricting-looking thing is a consequence of the vascular disruption. So again, we don't have a full understanding. And it may be that we separate these into two groups, that there's the actual physical banding diagnosis, and then a separate group that has a vascular event. One of the common things that I see are both upper and lower extremity bands around a limb that produces a deep groove in the ankle and has significant impacts in the limb below it. This is a foot. and that great toe has been tethered to the band around the ankle, which has produced a significant deformity through the ankle and the foot, as well as significant loss and changes in the digits in the toe.
So that would have had to be extraordinarily early in the gestation.
Absolutely, for that to be brought around.
Yeah. And that the limb could grow despite it.
Right. Well, so I would, again, this group probably would be able to suggest the timing of something like this. But for me, it had to have happened after the first 2 months because you have a formed foot. But then it had to have been enough that it could progressively deform that foot as the fetus grew. So I would tend to say that I would see this happening mid to early late pregnancy. But again,
So you would, in that situation, would there have been 5 digits originally, and then they are atrophied?
So having looked at many kids with amniotic band syndrome, I think what happens, and I have some pictures coming up, I think what happens is a fully formed limb occurs in the first 2 months of pregnancy.
Okay.
And then something happens, whether it's a physical thing, whether it's a vascular thing, changes, tethers, compresses, whatever the part you're talking about, that causes things to sort of melt and deform from that point down. So there are fenestrations associated with amniotic band, and I have some pictures of that coming up that sort of, for me, lends credence to this idea that there was something and then it was changed, and that change is what produces all of these deformities. So again, I think there's still evolutions in the understanding of amniotic band syndrome, but I see that consistently across fingers that have it. So we'll come back to that in a few minutes. So another scenario where surgery before 1 year would be important is for syndactyly of a border digit, most especially the thumb and index finger, where the length of the index finger is so different from the length of the thumb that when those two are tethered, if you leave that for too many months, you'll get significant angular bone deformity from the tethering of those two very disparate digits. So that I usually release early. We also will start lengthening and centralizing radial deficiencies where there's a significant angular deformity through the forearm so that we can get that stretch on the neurovascular structures early, and that will be done around 6 months of age. So these are the conditions that we'll go through, and because it's already after 8, I'm going to run through them quickly just so that we can see the befores and afters, because I think that's important. So each one is preceded by a cartoon picture that will sort of give you a chance to guess at what's coming. Syndactyly is the most common anomaly in the U.S. It's associated with syndromes like Apert syndrome, which has a unique rosebud-type syndactyly, Poland syndrome, which is absence of pectoralis muscle associated with syndactyly and radius hypoplasia. Most common in the long and the ring finger, presents with varying levels of syndactyly from partial to complete. This is a partial syndactyly. You have varying levels of syndactyly involving the nail and or the bone. So on the right you see there the bone at the end of the syndactyly is separate. On the left here you see the bones are fused with nail plate fusion. Syndactyly division is very successful. It's important to take care to place the web in the right place and with enough width. The top pictures are a child with Down syndrome, and that's one of the most common presentations in Down syndrome. The fingers are a little short. The small finger has a short middle phalanx. The syndactylies tend to be simple and complete, meaning that there's not a lot of bony involvement, and the nails are pretty well formed even if they're fused. That's very different from the syndactyly you see on the bottom, where all the bones are fused, the nails are fused between the ring and the small finger, and as a result you get a lot of angular deformity of the fingers. So that's the picture on the bottom right is mid-procedures. I separate them. You can't separate them all at once. You have to separate the digit on one side and then come back a few months later to separate the digit on the other side. The reason behind that is that you could compromise the blood supply to the central digit and end up having loss of that digit.
And do a Z-plasty.
So you do a specific, do you see my picture on the drawing? Yeah. So that rectangular flap is what you lay in as the web space. Because our webs are not actually a point, they're actually sort of a flat space. So you do a flat web into the web space and then a series of those oblique flaps along the side of the finger. These all need skin grafting because there's never enough skin to cover all of the defect. And I take the skin from the front of the elbow now, which leaves just a straight line where you have a natural crease, and it's a much nicer match for the skin of the hand than the groin skin is. The dermis is about the same thickness, and the skin color and hair potential is about the same.
Do you need a lot, or do you know?
You can get a lot. You can take a piece that's this wide and 3 centimeters wide.
We're all pinching our arms.
I know.
They're little babies, and I cast them in this position.
Wow.
So I take all the tension off of it, and their skin is very stretchy. And so the only scenario
you could take my elbow right here. No charge.
These little ones sadly don't have that yet. And all the parents are like, can you take my skin? It's less successful, unfortunately. So we take it from them, but the morbidity associated with that donor site actually is minor. They just end up with a little straight line in the natural crease. And it's protected in the cast. So I no longer take groin harvest for my surgery. Again, when they're small, they recover better. So the right age to do these syndactylies is about a year. They don't remember it at all. The skin is very malleable, and the grafts all take it close to 100%. So here's a different kind of deformity. This is polydactyly. We'll talk about some polydactyly because that's the second most common hand anomaly in the U.S. It can occur at multiple levels. The outcomes are generally good if you retain the most ulnar thumb. So looking at both of those pictures, the most ulnar thumb is the one closer to the index finger. As long as that is the better thumb, you have excellent outcomes. The problems come when the better thumb is the radial thumb, and you're having to take out that ulnar thumb and rebuild all kinds of things. And those thumbs tend to be more compromised, is a better way to say. Frequently, the thumbs are hypoplastic or underdeveloped, just as a consequence of the polydactyly process. It's worth mentioning preaxial polydactyly, which I think of as a completely different thing than true polydactyly. True polydactyly is inherently a part of the hand. Preaxial and postaxial polydactyly, in my mind, that is not a part of the hand. Those are little extras that came off before we went on and formed a hand. The hand forms in a thumb to small finger direction. So I think of preaxial polydactyly as you're going along, you make the radius, we're about to make a thumb, whoop, we made an extra finger, and now we make the thumb and go on all the way over. So these are not inherently, you can see that those preaxial ones don't share bones, they don't really share the joint, they don't really share any common structures with the thumb that you're retaining, and so I think of this as a different process. These can either be tied off, if they have a wide enough base, the one on the left has a narrow base, you could tie that off. If they have a wide enough base, it's better to do a little V-shaped incision that gives you a flat, minimal scar, and it also decreases the risk of bleeding and wound opening and all of that come from trying to tie off too big of a pedicle. True polydactyly, the most common type is type 4, where you have both proximal phalanges and distal phalanges duplicated. They come with significant deformities. In this case, it required an osteotomy, straightening of the thumb, the radial thumb that we kept, and a pin to let that heal for a month. The second most common is type 2, which is only duplication of the distal phalanx. And again, you have to decide which thumb to keep. This procedure, the Bilhaut procedure, is where you keep the outer portions and you bring them together. This is a good idea when the two thumbs are almost identical, as in this picture. In general, you prefer to keep the bigger thumb and get rid of the smaller thumb.
And sorry, is that one nail? Or?
So that is a nail on top of each distal phalanx that is fused in the middle. So you take out, in this procedure, you take out the central portion between the two nails and bring them together.
Is there a need to actually do that repair? Because that thumb may very well be pretty functional.
So that is, and the argument in favor of doing this is that we are very much a touch-based culture now, typing and very digital, and a broad thumb like that makes it very hard to do that. And then the secondary reason, and I always say it's secondary because I don't think it should be the guiding principle, but that is a very cosmetically visible deformity that will impact the child. I also will say that I have treated children who have been adopted or have moved here with families from third world countries who have anomalies like this and others who have grown up always having their hand in a pocket, always. And even after we surgically repair them to what would be more like their peers, they have already developed the behavior pattern of hiding their hand. So I see that in the older kids from other countries, and I think that's not it's worth mentioning. I don't think it should be the reason, but it is an important component.
And how does that nail bed do over time? Does it
So
get together?
I prefer, if there's a size difference, to keep bigger thumb, even if it's a little small, because that nail will always have a deformity in the center of it, because you've sewed together germinal matrix, and so it's not going to be normal. There is a nail. It does grow out, and the majority of them are actually one solid nail, but they have deformity in the nail, and it doesn't quite lay flat, and it is different. So we are at 8:10. Should I rush through so you can see it all, or would you like me to keep going at a steady pace?
No, let's rush.
Okay, because the people need to go. So thumb deficiency, I'll just briefly show you. This is one of the classifications that's very helpful. See the red line? Everything to the left of the red line, you keep the thumb. Everything to the right of the red line, you get rid of the thumb, and you turn the index finger into a thumb. The ones that you keep, you can augment them by widening the web space, transferring a muscle to bring it into better opposition so that they have better pinch function. And the ones that are to the right of the red line, you get rid of the thumb. That thumb is not reconstructible, so you remove the thumb and you turn the index finger into a thumb, and this works very well. These thumbs function at 95% of what a normal thumb would work at. The hardest thing for the parents is getting over the reductions down to 3 fingers from 4. And this difference is finger hypoplasia, and this is very common. There's not a lot we do for it. In some cases, we will move the web spaces proximally to make the fingers function as longer fingers, and in other cases, rarely we'll move bones from the toes and try to get a little length of the fingers so that they can have some pinch function. Here's another example of brachydactyly, or hypoplastic fingers, with a syndactyly, where moving that web space up was all that was needed to make those fingers work better. This is the amniotic band picture, and so I do want to spend a minute talking about this. The pathognomonic finding in amniotic band syndrome for me is fenestrations. So again, I think that the whole hand forms, a process happens by which things are changed. Everything from that point down is changed, and if there was a web space from that point proximally, there still is a web space. So surgically, when I separate these are web spaces, and you separate that distal attachment, and there's a nice web space there. There always is associated bone loss and bone changes associated with the amniotic bands. Again, we talked briefly about the banding in the ankles. I release these by doing a series of Z-plasties to get rid of the abnormal contour and promote both lymph and blood flow across that. They always have a scar, but the contour is much more normal, and you can see that the appearance, at least from a distance, is good, except for the scarring. Here's another example of this baby is 2 weeks old with these amniotic band, and you can see all the web spaces are there. It's as if the fingers just kind of got tied together and everything sort of fused. And the picture on the bottom left is showing that fenestration, and to the right you see post-reconstruction. You can still see a lot of scar tissue and significant deformity in the way the bones and the joints and the tendons work distal to the process. But he is using this hand as 4 separate independent fingers. Central deficiency or cleft hand, the phrase that goes with this is a functional triumph and a social disaster. These hands work very, very well. As long as there's a post and a thumb of some sort, they work very, very well. You see it frequently in the feet. The autosomal dominant variant will involve all 4 extremities. The central deficiency can be reduced. As long as you're not compromising function, you can reduce that to make that cosmetically look better. The congenital transverse failure formation, it's uncommon. The below elbow version is the most common presentation. The conversation about prosthesis comes up all the time. There's a great study out of the Schreiner system talking about the use of prosthetics for functional identified activities is valuable, but putting it on them when they're young is not. You want them to learn the sensory input that they'll get from the end of the stump. So there are scenarios where prostheses can be useful. The one that I think is most relevant is a prosthetic to help hold the glove in baseball, things that can be made specifically for the activity that the child is interested in. Radial club hand, I'm going to move through this one really fast. We've seen the picture of that in the beginning. It comes in a lot of variety from mild hypoplasia to complete absence of the radius. Obviously, surgical intervention is designed to put the hand at the end of the arm so that you have maximal length. We also often grow that arm longer. The postnatal plan, in my mind, I'm going to observe how the child moves and uses the hand. X-rays are not needed at birth. I usually do those at about 3 months of age. The first follow-up for me is usually at 3 months of age again, because at that point the child has started using the limb and I can get a sense of function, early function. And with the exception of certain things like radial club hand and arthrogryposis, I will see those patients earlier. OT can begin very early stretches with a lot of these patients. And so that Adrian Flatt is the pivotal congenital hand surgeon in our history, who said that in a child whose hands are deficient or even absent, but whose brain is normal, that child will develop almost normally. And I emphasize that repeatedly in both prenatal and postnatal consultations with new parents. As long as the hand is the only thing involved, your child is normal. They will figure out how to make that hand work. There's a child with the autosomal dominant form of cleft hand. He's got it on both hands and both feet. I've operated on his feet because he had sores rubbing in his shoes because he plays on a select soccer team. He does not want me to touch his hands because they work great for him. So we're not doing ever.
Soccer.
He does the throw-in, he plays goalie sometimes. I mean, he's a totally functional, happy kid. Thank you.
Wow. That was fantastic.
I ran out of all the time for questions, but anybody
has I just for people, I don't know if there's anyone out in Cyberland has any questions, but let's turn on the light and just amazing stuff. We're so lucky to
I feel like an imposter talking about the ultrasound images because, you know, I'm just learning about them from you guys. So.
Yeah, I do want to say one thing is I have, there are some centers who have LAMSA bands in utero.
Oh, okay.
And I saw a picture from the Barcelona group where you actually see the band and cut it. I don't know whether it improved.
Were those the body wall ones that they did, or was it?
No. There was actually the two I saw. I think one was a leg and one was an arm.
Oh, how
but
interesting.
they cut it, yeah. And who knows whether it, you know, because it's
well, the
probably later.
That foot, if we could have done that foot would have been radically improved.
Even though it was in the second trimester and it had already.
Well, I can tell you the outcome of that, but that child's running around. So we divided that and then removed the amniotic band. We casted the foot around and got it plantigrade. And that kid's running around and wearing shoes and he's fine. But it maybe could have saved some of that by doing intrauterine.
So basically, it doesn't sound like you do surgery early, and I think your counseling is so important, you know, with these families, because we have seen some families not continue because of some limb issues. So.
Which I think is a tragedy, because if you spend a day in my clinic and meet these kids, I mean, just look at that guy.
Yeah.
That is one thriving child, and he has 4 limbs involved.
Yeah. And
he's a complete success as a person. And so I would hate for a family to decide to end the pregnancy for fear of what this limb anomaly means, if that's not all it is. It's just a limb anomaly.
And thumb is really important, right? So if you, can.
So we do everything to create a thumb. Okay. I had some great pictures, which I didn't put in because it was getting long, of kids who are born with all sorts of, you know, segmental defects with very short arms, with, you know, 3 digits that are sort of malformed. And I have polycized even those kids just to get something in front, and they are now, you know, able to bathroom independently, and they're handwriting, and they're feeding themselves, because this is very hard.
So it's the same muscles, but you just
so if you have, and even if you don't have the right muscles, you can move it and create a post. If it doesn't move, you can still pinch to it. But yeah, the muscles that do the side-to-side motion become your thenar muscles that do this. So you shorten it and you turn it 180 degrees, and it becomes a thumb.
Amazing.
Polycization.
Wow.
We have one coming up next month. Should any of you want to come in the hour and look at it?
Yeah. Amazing. So thanks. So we need you for every family that comes in. And is anything do we say things that are wrong to these families?
I haven't found that at all. The group that seems to misinform families the most are the therapists, hand therapists, or occupational physical therapists. And I educate them as much as I can through the family so that the information is better. But no, I think you guys I'm learning from you as well. Yeah, I think you're doing
having like a lack of a radius, does that make your surgery more difficult? If you don't have a radius and a thumb, Is ablation more difficult?
So the more complex the deformity, the harder the reconstruction, but we still do it. For example, there is a patient who I saw through you guys who needs that and has a very short radius and needs a thumb. And we're working through that conversation because it's very hard for families to go from what looks like a 5-finger hand, even though it's not working, to going to 3 fingers and a thumb. So we're working through that, but when that's done, her hand will work much, much better, and she will have pinch and grasp. But it makes it a little bit harder, yes.
Yeah. Any other questions? Okay, really pretty, just amazing.